Today we will discuss about evaluation of hypokalemia. So when we see hypokalemia in a patient, how to evaluate the causes, probable cause of hypokalemia. So for this, what we will do is we will have 4 segments to make it very easy and practical. So first is because of decreased intake. Then is potassium loss is more, that is excessive increased loss. Then third point is whether potassium is there normally in the body, but it has got redistributed inside the cell. So redistribution. Fourth one is loss of potassium's friends. So loss of potassium friends. So in that sadness, even potassium will be low. So we'll deal these 4 segments. First is about decreased intake. So if any individual is taking lesser potassium rich diet, then here just imagine our kidney is like a boy. Kidney is like a boy who has 2 girlfriends. One is sodium, other is potassium. So this boy always need at least one of his girlfriend with him. So if sodium is not there, it will keep potassium. If potassium is not there, it will keep sodium. So if the individual is taking less amount of potassium in his or her diet, there will be decreased potassium. So body will try to retain sodium more. So retention of sodium occurs. And we know that if there is excessive sodium in body, it will lead to hypertension. So these individuals are at risk of developing hypertension. But the thing is, decreased intake itself leading to hypokalemia is rare. Then comes increased loss of potassium. So it will be lost either renally or extrarenal. In extrarenal, mainly it is because of bowel diseases, even diarrhea. And in renal, just understand the role of potassium, that is relation of potassium with the nephrons. So mainly all the nephrons so this nephron diagram schematically I intentionally made the distal tubules, that is collecting duct, a bit larger to explain it. So what happens, always our kidneys will try to have the intention to excrete the potassium. So whatever potassium we take every day, about 90% is excreted through kidneys, kidney excretion, and about 10% is lost in the stools. So kidneys are always focused to excrete potassium. That will happen with the help of ENaC channels mainly. So here we will have ENaC channels. So what happens, as the filter pass through this lumen, when it reaches here, kidneys or nephrons will always reabsorb sodium. So they will reabsorb sodium, and in exchange they will always lose potassium. So this is the thing. So major relation is related with ENaC. Now how does it help in evaluation of potassium? Suppose there is excessive activity of the ENaC, that is genetically or by some mutations. If ENaC is excessively active, that is gain of function mutation of ENaC, it will lead to more and more reabsorption of sodium, leading to more potassium loss. So that is one thing. That is nothing but Liddle syndrome. Liddle syndrome. Or some other object or some other thing is making ENaC to act excessively. For example, aldosterone. Increased aldosterone will just randomly stimulate ENaC channels. So they will be active excessively. That's why leading to more sodium reabsorption and more potassium excretion in exchange. Even excessive mineralocorticoids, even glucocorticoid excess like Cushing's or ectopic ACTH secretion. So even glucocorticoid excess, because that will also have some mineralocorticoid activity. So all these things will overstimulate the ENaC. Similarly, some medications, for example penicillins or aminoglycosides, antibiotic, even amphotericin, amphotericin. So all such medications will again overstimulate ENaC. So the overall point is they are all targeting just one site and making it hyperactive. So it is leading to more sodium reabsorption and loss of potassium, causing hypokalemia. And one more thing in renal losses is usage of diuretics. Obviously, they will lead to loss of multiple things like sodium, water, and potassium also. So that is a different mechanism, but we have to remember it in excessive loss. So this is about second segment, which is very, very important when we are evaluating hypokalemia. And we can tell that in all these manifestations, as there will be excessive sodium reabsorption, obviously they will have hypertension also. So here we can remember that they will have associated hypertension. This is the point. Coming to the third segment, that is redistribution. Means potassium is there normally in the body, but it has got redistributed intracellularly. Now what are the things which will redistribute potassium into the cells? We know that some medications such as insulin, even beta agonists like salbutamol, and sometimes some excitatory states, for example, increased sympathetic activity in the body, like giving sympathomimetic agents, for example salbutamol, or even some dieting agents might also contain hidden sympathomimetic medications, for example ephedrine and pseudoephedrine. So these sympathetic overactivity will stimulate sodium potassium ATPase that will lead to hypokalemia. Similarly, increased thyroid levels will again stimulate sodium potassium ATPase, leading to hypokalemia. And sometimes what happens in a malnourished individual who is admitted for some other cause in hospital, as a supplement we will load them with dextrose. So in malnourished, loading dextrose will lead to surge of insulin, again redistributing potassium into the cells, causing hypokalemia. So these are the few things. Just to give it at a glance, whatever the activities which will lead to increased sympathetic system function, leading to sodium potassium ATPase excess activity, will cause hypokalemia. This is about redistribution. Then we told that there will be loss of potassium friends. So two closest friends of potassium are magnesium and acid. So if there is hypomagnesemia, there will be associated hypokalemia. And if there is decreased acid, that is alkalosis can also lead to hypokalemia. So this is the easiest way to approach the probable cause of hypokalemia. Just to summarize, decreased intake, increased loss, or everything is fine but redistributed there itself, or there is loss of magnesium or acid H+ ions. So intake is very rare, and when it comes to loss, just look for renal loss. Mainly focus on ENaC hyperstimulation. Coming to redistribution, we have to think of any supplements like this in the form of medications, or if there is excessive activity of sodium potassium ATPase. And we should not forget close friends of potassium, that is magnesium and loss of protons. Hope you got the point. Thank you so much.